Good morning to you all. Today's topic is on bone loss and patterns of bone destruction. Learning outcomes are at the end of the topic, the student should be able to describe the concept and pathogenesis of bone destruction in periodontal disease, list 5 patterns of bone destruction in periodontal diseases, classify intra-bony defects, differentiate the bone loss patterns during radiographic interpretation. Introduction. Periodontitis is always preceded by gingivitis, but not all gingivitis progress to periodontitis. The transition from gingivitis to periodontitis is associated with changes in the composition of bacterial plaque. In advanced stages of disease, the number of motile organisms and the spirochetes increase, whereas the number of coccoid rows and straight rods decreases. The cellular composition of the infiltrated condylar tissue also changes with increase in severity of the lesion. The existing bone level is the result of past episodes of bone loss from the effects of periodontitis. The degree of bone loss does not necessarily correlate with the depth of the periodontal pockets, the severity of ulceration of the pocket wall, or the presence or absence of X-ray. So before moving into the pathogenesis of bone destruction, we would like to know that periodontal bone architecture. So the bone contour follows the contour of overlying gingiva. The alveolar crest is the most cervical rim found in the alveolar bone proper. When it is healthy, the alveolar crest is slightly apical to the cemento-enamel junction. That is about 1.5 to 2 mm, and the alveolar crest of adjacent teeth are also firm in height along the jaw when they are healthy. And also the alveolar process that comprises of compact bone adjacent to the periodontal ligament, that is called lamina dura. So which is very critical, or which is very important in case of while examining the radiographs in case of pathologic lesions. Then comes coming to the pathogenesis. So in details, it starts from the stages of gingivitis and then to the formation of pocket and then to the bone destructions. So pathogenesis under that which comes with the gingivitis, that is inflammation of gingiva. So it has been described in various stages, that is initial lesion, early lesion and established lesion. So Page and Schroeder summarize widely scattered studies on the pathogenesis of periodontal disease. So first one, that is the initial lesion. The days of occurrence, that is 2 to 4 days, and blood vessels like vascular dilatation and vasculitis infiltrated with PMNS, that is in the junctional epithelium and circular epithelium, and a predominant cell is polymorphonuclear neutrophils. Collagen, there will be perivascular loss and clinically gingival fluid flow. Early lesion that arises within 4 to 7 days, and blood vessels with vascular proliferation and retipex atrophic areas can be seen in junctional epithelium and circular epithelium. Lymphocyte is the most predominant cell type, and collagen increase loss around infiltrate, and clinical features erythema and bleeding on probing. The third stage of gingivitis is established lesion, which occurs within 14 to 21 days, and it's with this stage 2 plus blood stasis, that is vascular proliferation. Along with that, you can see this blood stasis, and here the junctional epithelium and circular epithelium will be more retipic formation can be seen, and atrophic areas that is more advanced. And here the cell type is plasma cells, continued loss of collagen, and the clinical features changes in contour, color, texture and size. So we can see that some of the cases will get a progress to periodontitis. It is not necessary that all the cases of gingivitis will progress to periodontitis. Same, or it will have postlated contained gingivitis in which T lymphocytes are preponderant as the lesion becomes a B lymphocyte. So usually when there is a like T lymphocyte cases, you will just sustain it as gingivitis, and when it comes to B lymphocyte lesion, becomes progressively destructive. That is the case where it progresses to periodontitis. Then coming to the pathways of inflammation from the gingiva into the supporting periodontal tissues in a patient with periodontitis, you can see that interproximally. So it might enter the blood vessels, and that is from gingiva into the bone, you can see, and from the bone into the periodontal ligament. and also from the gingiva into the periodontal. So these are the three pathways of inflammation, that is from gingiva to the bone, and that is in interproximal region, and in facially and lingually from the gingiva along the outer periosteum, and from periosteum into the bone, and also it can be from the gingiva into the periodontal ligament. So after gingivitis, then coming to the pocket formation, this we have already discussed under periodontal pockets. So this is the inflammatory change. If there is progressing, there will be amount of increased amount of PMNS in this area. So there will be increased dilated and engorged blood vessels. There will be change in the epithelium and then in the conti tissue, and the cellular and fluid inflammatory X-ray causes degeneration surrounding the conti tissue along the gingival fibers. So what happens? There will be increased amount of PMNS influx into the area, and where there will be like apical proliferation of the cells can be seen in this area, like proliferation of the cells of the junctional epithelium can be seen like finger-like projections, and which causes the coronal portion to get detached from the root surface, and ultimately it leads to the collagen destruction and reaches the areas, and it leads to the collagen destruction. So as the periodontal disease progresses, the collagen fibers and the connective tissue attachment to the tooth get destroyed, and the epithelial cells proliferate apically along the root surface, and which leads to more deepening of the periodontal pocket. As the junctional epithelium migrates apically, so too does the extent of this tissue exudate, which leads to the activated osteoclast, which initiates the bone destruction. And also, it can be explained either by the bacterial factors or host factors. So, bacterial factors will be acting on the bone progenitor cells to convert into the osteoclast and finally the bone resorption. And also, some of the host factors like prostaglandins and its components. So, it will be also leading to the osteoclast formation and the bone resorption. And also, some of the other factors like systemic diseases like osteoporosis, and also trauma from occlusion also could like stimulate this osteoclast and will lead to bone destruction. The activation signaling is this activation and signaling is modulated by a wrangle, that is receptor activator of nuclear factor like kappa ligand and rang and osteoprotagrin. These three noble members of the tumor necrosis factor ligand and receptor superfamilies, and along with that the hormones and cytokines modulate the osteoclastogenesis by enhancing the osteoclast differentiation, activation, lifespan, and function. So, as we told that, which leads to this osteoclast activation and leads to bone resorption. So, in the how it happens, that is in narrow spaces, this resorption proceeds from within and causes a thinning of the surrounding bony trabeculae and an enlargement of the marrow spaces. So, this is followed by the destruction of bone and the reduction in bone height. Normally, fatty bone marrow is partially or totally replaced by a fibrous type of marrow in the vicinity of resorption. So then coming to the radius of action. So the authors, Garan and Cho in 1979, he made the conclusion on radius of action is that locally produced bone resorption factors are need to be present in the proximity of bone to exert their action for bone loss. And Payton-Schroeder in 1982 made the conclusion that the range of effectiveness of about 1.5 to 2.5 mm within which bacterial plaque can induce bone loss. That means beyond 2.5 mm there will be no effect, there will be no bone loss. And you can see that interproximal angular defense can occur only in spaces wider than 2.5 mm, because the narrower spaces will be destroyed completely, then it moves to the angular defect. Then Frank R. in 1978 found out that larger defects greatly exceeding a distance of 2.5 mm from the tooth surface that is usually seen in aggressive periodontitis. It might be caused by the presence of bacteria in the tissues. So coming to the rate of bone loss, Rowe and Associates in 1986 did a study on Sri Lankan tea laborers with no oral hygiene and dental care. He found out that the facial surface, the rate of bone loss is about zero point 0.2 mm yearly, and also the proximal surface it's about 0.3 mm yearly. And the rate of bone loss may vary depends upon the type of disease present. So it can be categorized as three subgroups. There is rapid, moderate, and minimal based on interproximal loss of attachment and tooth mortality. So they found out that in rapid progression of periodontal disease, about 8% of the population had loss of attachment of zero point 0.1 to 1 mm, and the moderate progression of periodontal disease, they have found that 81% of the population had loss of attachment with zero point 0.05 to zero point 0.5 mm, and with a minimal or no loss of attachment category, that is only 11% of the population had zero point 0.05 to zero point 0.09 mm. So that is what we are telling, that the periods of destruction in case of periodontitis occurs in an episodic intermittent manner with periods of inactivity or quiescence and destructive periods that result in loss of collagen and alveolar bone and deepening of the periodontal pocket. Four theories have been found for the onset of destructive period. The first one is that bursts of destructive activity are associated with subgingival ulceration and an acute inflammatory reaction, which results in rapid loss of alveolar bone. The second school of thought is that burst of destructive activity coincide with the conversion of a predominant T lymphocyte lesion to a B lymphocyte and plasma cell infiltrate. Then the periods of exacerbation are associated with an increased unattached motile gram-negative anaerobic pocket flora, and period of remission coincide with the formation of a dense unattached non-mobile gram-positive flora with a tendency to mineralize. And the fourth one is that tissue invasion by one or several bacterial species is followed by advanced local host defense that controls the attack. So these are the four theories for destruction. So next, moving on to the normal variation in the alveolar bone. So there can be like various considerable variations exist in the morphological features of alveolar bone, which affects the osseous contours. So it can be thickness, width, and crustal angulation of the internal septa, thickness of the facial and lingual alveolar plates, presence of dehiscence or fenestrations, the alignment of the teeth, root and root trunk anatomy, and root position within the alveolar pores, proximity with the another tooth surface. So these are some of the factors which might alter the normal or morphological features of alveolar bone. So which affects the osseous contours produced by the periodontal disease. What are the factors determining more bone morphology in periodontal disease? So there are several factors that determines the bone morphology. There is normal variation in the alveolar bone, as we said before, and exostosis and trauma from occlusion, buttressing bone formation, and foot impaction. So we will move on to each one later. First one, exostosis. They are outgrowths of bone of varied size and shape that occur as small or large nodules, sharp ridges, spike-like projections, or any combination of this. So the parietal exostosis have been found to be 40% of cases. So this is the picture that's showing the exostosis. That is the outgrowths of bone. You can see with varying size and shape in different areas. Then coming to the next factor, that is the trauma from occlusion. As you know that trauma from occlusion, that is what, when occlusal forces exceed the adaptive capacity of the tissues, which causes the tissue injury. So this resultant injury is termed as trauma from occlusion, and the force which causes it is called traumatic injury. Okay, and the trauma from occlusion may be a factor in determining dimension and shape of bone deformities. So it can be reversible also. That is, maybe a factor in determining the dimension and shape of bone deformities. It may cause a thickening of the cervical margin of alveolar bone or a change in morphology. That is, usually it forms like there will be a slight amount of bone change. Sometimes it will get adapted, or sometimes it leads to the bone deposition also. That is, buttressing bone or angular bone defects, on which the inflammatory changes will later be superimposed. Then coming to the buttressing bone formation or lipping. Bone formation sometimes occurs in an attempt to buttress bony trabeculae weakened by resorption. So when it occurs within the jaw, it is called as central buttressing bone formation. So that is endosteal cells deposit new bone which restores the bony trabeculae and reduces the size of bone marrow spaces. So when it occurs on the outer surface, external surface or facial or lingual surface of the alveolar plate, it is called as peripheral buttressing bone formation. So the latter one, that is the peripheral one, which causes the bulging of bone contour, so which is called lipping, which sometimes accompanies the production of osseous craters and angular defects. So that is buttressing bone formation can be either a central or peripheral. So next coming to the foot impaction, which is one of the most frequent complaints of patients, there is foot impaction. So it mainly due to the abnormal proximal contact. So there is interbone defects occur where proximal contact is abnormal or absent. So this pressure and irritation from foot impaction contribute to the inverted bone architecture, or you can see that reversible bone architecture. In some cases, the poor proximal relationship may result from a shift in tooth position, also some of the migration of the tooth also, that will create this space for foot impaction. So because of the extensive bone destruction preceding foot impaction, in such patients foot impaction is a complicating factor rather than the cause of bone defect. Then coming to the aggressive periodontitis. So aggressive periodontitis, as you know, it's very aggressive in nature, which results in rapid loss of attachment and bone loss. So which will be seen mostly around incisors and first molars, particularly in cases where disease is observed in young patients. Okay. Although such bone loss is usually horizontal in nature around incisors and or although it's like it is a horizontal bone loss in generally around incisors, but you can see that here a vertical or angular pattern of bone destruction is found around the first molars in aggressive periodontitis. Then coming to the patterns of bone destruction. So this is a very important. There are different patterns of bone destruction. So after going to the details of each one, you will be able to differentiate different bone patterns in radiographs. The first one, that is the important one, that is the architecture. It can be like a positive architecture or a reversible architecture or a negative architecture or a flat architecture. So the ideal one, the positive one, is that the interdental bone will be coronal than the buccal bone. That is the positive architecture. Negative architecture, that is interdental bone, will be lesser than or apical to the buccal bone. That is the negative one. Flat one, you can see that the both buccal and interproximal bone will be at the same level. Then coming to the horizontal bone loss and vertical type of bone loss or angular bone loss. Under that, there can be different types of defects, that is based on the number of osseous walls, that is osseous walls, it is 3 or 2 or 1 wall defect. Then coming to the combined defect, so it will be a combination of this 2 wall defect and the 3 wall defect, and osseous craters are present and the bulbous bone contours. Under that, this buttressing bone formation. Under that, central or peripheral, then exostosis and ledges furcation involvement. Under that, horizontal type of bone loss and vertical type of bone loss. First comes, that is the horizontal bone loss. That is the most common type of bone loss you can see in periodontal disease. So you can see that it is a horizontal amount of bone loss. It is reduced in height, but the bone margin remains perpendicular to the tooth surface. It is almost like horizontal perpendicular. And this one is the vertical bone loss. You can see there is angular bone defect. That is in a bone loss will be in an oblique direction. It leaves a hollowed out trough in the bone alongside of the root. You can see this. But base of the defect is located apical to the surrounding bone. So coming to the classification of osseous defects, so under intra-bony defects, it can be classified under Goldman and Cohen in 1958. That is, it can have like mainly based on the number of osseous walls, can be either 1 wall defect, 2 wall defect, or 3 wall defect. So coming to the details of each wall of defects, there is 1 wall defects. Intra-bony defects means that only 1 wall is present. There is defects limited by one osseous wall. and the tooth surface. So only one wall will be present. There is one wall defect. This is the diagrammatic representation. This is the clinical representation. You can see that there is one wall will be left here. So that is this one. You can see that here it is the this side only one wall will be present. So here also you can see that only one wall defect, or you can call it as hemiseptal defect. Then coming to the two wall defects, so it is limited by two osseous walls and the tooth surface. You can see that two osseous walls will be present. Either it can be like mesial and the lingual side. So all the buccal areas will be low. So only two walls will be present. You can see that that is the two wall defect. And three wall defects, you can see that there is defects limited by three osseous walls and tooth surface. So it will be like you can see that three osseous walls will be present and one of the walls will be lost. You can see that there is still one, the mesial one is lost and the buccal lingual will be present. So this is more like a degenerative capacity and good prognosis compared to the other two defects. Then coming to the combined defect, that is combined type of osseous defect, you can see like one side will be like more number of walls will be in the apical portion, and occlusal surface it will be like less number of walls. That is a combined type of osseous defect because the facial wall is half the height. You can see that this facial wall, the buccal wall will be half the height of the distal one distal one. So that is and in the lingual, so this is an osseous defect with three walls in its apical half and two walls in the occlusal half. So this is, you can see that the continuous defects that are involved more than one surface of a teeth in a shape that is similar to a trough called circumferential defects. Usually this type of defects are called circumferential defects. The number of walls in the apical portion will be greater than that of the occlusal portion. So this diagram is clear that the facial surface is half that of the other two walls. So apically it will be three wall and the occlusally it will be two wall. Then coming to the osseous craters, you can see this is the osseous crater. They are specific type of two wall defect. So two walls will be present. They present as concavities in the crest of interdental bone that is confined with the facial and lingual walls as a cup or bowl shaped defect in the interdental alveolar bone. You can see with bone loss nearly equal to the roots of two contiguous teeth and more coronal portion of the buccal and lingual crest. Craters have been found to be make up about one third of all defects, about two-thirds of all mandibular defects. They occur twice as often in the posterior segments than in the anterior segments. So, what might be the reason for this osseous craters? That is as a result of apical spread of periodontitis along two adjacent roots in a relatively narrow interproximal area. So, that will be the reason for this osseous craters. And this interdental areas also collect plaque and are difficult to clean also. So this is the osseous craters. You can see this concavities between the adjacent roots in a relatively narrow interproximal area. You can see this amount of uh, osseous this type of bone defect. Coming to the ram, in its purest form the term ram describes the deformity that results when both alveolar bone and its supporting bone are lost to a degree in such a manner that the margins of deformity are at different levels. So it will be like you can see that these regions like both like interproximal or the buccal bone will be higher in terms higher compared to the interproximal bone. So there is the ramp type of osseous defect, and the plane is there is a term applied when both the alveolar bone and the supporting bone is lost at the same degree, such that the margins of deformity are at the same level. You can see it can be considered horizontal bone loss about one tooth or portion of a teeth. So there is ramp and then coming to the reverse or negative architecture, as I explained before, these defects are produced by a loss of interproximal bone. So this is the reverse architecture. You can see that there will be loss in the interproximal bone, including the facial lingual place without concomitant loss of radicular bone. reversing the, so this will be the like positive architecture, and which leads to the negative architecture or reverse architecture. So these defects mostly seen in maxillary region. Then coming to the hemiseptum, that is same as that of the one wall defect. That means only one wall is present. The remaining half of an interseptum forming the interproximal wall of a one wall defect. So all the walls will be absent. That is all the. So here you can see that all the mesial, buccal and lingual walls have been lost. Only the distal wall is present. And then coming to the next osseous defect, that is ledges. Ledges is the name indicates they are plateau-like bone margins caused by the resorption of thickened bony places. You can see that this amount thickened like plateau-like regions. You can see that is a thickened body plate. So here it is more, this picture shows the more evidence of this ledges. And then coming to the bulbous bone contours, these are bony enlargements. You can see this is mainly caused by the exostosis or buttressing bone formation or adapting to function might be the reason for this bulbous bone type of bone contours, and they are more frequently found in the maxilla than in the mandible. Then coming to the furcation involvement, that is invasion of the trifurcation and bifurcation of a multi-rooted teeth by periodontitis, that is what furcation involvement. So it has been graded into different types by Dickman, that is grade 1, grade 2, grade 3 and grade 4. So in this picture it shows that grade 1, that is the very incipient or early stage of furcation involvement. Grade 2, you can see that like one or more furcation of same tooth, or like it has been lost some amount of bone, that is the that one wall will be lost, that is the which enables the entrance of the probe into the area, into the furcation area. So that is grade 2 furcation involvement. So it can be called as cul-de-sac, so with definite horizontal involvement. So this will not communicate with other furcations because alveolar bone attaches the tooth. Then coming to the grade 3 furcation involvement, as you can see that like both the buccal and the lingual walls have been low, so it which enables the penetration of the probe through and through. So bone is attached, no bone is attached to the dome of the furcation. And grade 4, you can see that it is also same as that, that is the interdental bone will be destroyed, which permits the through and through. But the grade 3, it will be covered by soft tissue, and grade 4, it will be clinically exposed. And then the another classification for this furcation involvement, that is mainly depends upon the horizontal compound, that is given by Ham in 1983. He modified a three-stage classification system and attaching the measurement to separate the extent of horizontal involvement. So here they have used a neighbor's probe to identify the amount of horizontal involvement. You can see that class 1 only less than 3 mm, and class 2 more than 3 mm of horizontal attachment loss but not through and through, and grade 3 it is like passing through and through. So it is mainly involved the horizontal component. Next comes that is a Tano in 1983 given the vertical classification that is based on the vertical bone loss. You can see that first one, there is for a vertical bone loss of 3 mm or less, and the third and the second one grade 2 or subclass B, it is vertical bone loss of 4 to 6 mm, and the subclass C, it will be from like greater than 6, that is 7 mm or more. So these are the main three classifications of furcation involvements. So we have covered the mechanism of bone destruction, the different patterns of bone destruction, and coming to the conclusion is that the amplification propagation of the inflammatory response to gingival tissues is critical to the pathogenesis of periodontitis. However, it is a spread of the response to areas and adjacent to the alveolar bone that drives the cellular machinery involved in bone loss. So, deciding on a diagnosis has several practical purposes. It sets the stage or context of for treatment planning. It helps in estimating outcomes, that is mainly in defining the prognosis, and also it facilitates communication with colleagues and patients.